We are recording it. We're doing this session on the history of mental health reform in Wisconsin. The idea being to learn from where we've come and not repeat mistakes of the past and build on what has already been done. We're having a little bit of Zoom fun, so please hover over the top right-hand corner of your tile and click on those three little dots. And then one of the options is rename. Please rename yourself with your name and your place and your organization, if that applies, and anything else that you feel led to share. As we get started, I just wanted to let you know that, number one, we are recording this. We will share this recording in a follow-up message, along with a few other things that we'll talk about later. And that this is going to be an interactive session. So you should have all received the executive summaries of the Blue Ribbon Commission report and the Mental Health Substance Use Infrastructure report. The Blue Ribbon Commission report was from the Governor's Blue Ribbon Commission in 1997, and the infrastructure report was from 2009. And along with questions for the small group discussions. If you didn't get those questions, please email Julia, and she's going to put her email in the chat, but it's Julia@NAMI Wisconsin, spelled all the way out, .org, and she can send them along to you. So the word about the Mental Health Action Partnership, known as MHAP for short. We are a new statewide community-led coalition gathering to improve coordination of and access to equitable, effective mental health care throughout Wisconsin, across the lifespan and across the continuum of care. We're gathering now because, as many of you know, there's increasing public awareness of the importance of mental health and a rising demand for care, and that is colliding with access disparities and workforce shortages. So this is a systemic problem. It's been with us for a long time, but it's really kind of coming into our faces right now. And we know that true system change will require a sustained, long-term effort across the whole array of stakeholders. So that's what we're about. We also know that we have a lot to learn. So we're going to be hosting regular learning sessions to explore and talk together about issues and practices that apply to our work as a statewide partnership. And we're going to start, as I said, by learning from the past, from mental health system reform in Wisconsin and previous efforts. We're picking up two important efforts this time. We may do some others as we go forward. We're delighted to have speakers today who have been integrally involved in two of those initiatives. Diane Greenlee is the retired managing attorney for Disability Rights Wisconsin, who served on the 1997 Governor's Blue Ribbon Commission on Mental Health, and Heidi Pankow, retired director of business strategy for TMG, who will discuss the 2009 Mental Health and Substance Use Infrastructure Study. I'm going to go through the agenda just to give you a sense of the flow. Before we start with Diane and Heidi, Dr. Rick Imler, who's a member of MHAP and a child and adolescent psychiatrist, and also a former chair of the Wisconsin Council on Mental Health, will introduce us to the CDC's elements of policy development, just to give us a framework for an example for how to think about policy and long-term system improvement. And then Diane and Heidi will give brief presentations, and then they'll focus on why the studies were done, their study was done, what they found, what helped or hindered implementation of their recommendations, and what didn't take hold adequately that might still apply in some form or fashion to us today. And I'm going to say, Zoom is fun. As we speak, please write down your questions and thoughts on paper or on some other screen, because when we go into breakout groups, the chat will disappear. So if you have questions, please do write them down. And then after they speak, we're going to go into breakout sessions of 6 or 7 people each. There will be a facilitator and a scribe in each of those sessions. And we want you to talk about some discussion questions that we sent out, and I'll read those to you before we go into the breakout session.
Rachel, is this 382G my Spectrum? Do you have Spectrum?
So I think I'm gonna. Okay. And then after the breakout sessions, we'll be in the breakout sessions for probably about 25 minutes. And after that, we're going to come back into the whole group and hear your main takeaways. Kathy Markland from WAFCA, Executive Director of WAFCA, will facilitate that discussion. And we'll look at what we've learned and the implications for our work going forward. And then at the end of today's session, we'll discuss next steps, including an online mental health action partnership meeting on January 31st that you're all invited to. And so with that, I'm going to turn it over to Dr. Imler. Just a minute. Gonna get my technology going. There we go. To talk to us about the elements of effective policy development, the CDC model.
Rita, thank you. The rationale for sharing this is we're going to be hearing about some major efforts in Wisconsin. And I've been puzzled over the years, having been involved with different policy and system reform efforts in Minnesota and Wisconsin, what works, what doesn't, and why. Really wrestled with that. So in doing a literature search, there's many frameworks or scaffolding to develop good policy, and really mental health system reform is often multiple policies. So that's the background for offering this. So yes, go ahead, Sita. And just that's a quick definition of policy. I will say that I'm going to go very quickly because I don't want to distract from Diane and Heidi's presentations. Next slide, and you will be getting these slides. So in the CDC recommended model, there's two core elements. In the middle, the stakeholder engagement and education. I'm really thinking broadly about what stakeholder means. And then ongoing evaluation, the capacity to really assess what we're doing. In the periphery, there's the 5 steps, if you will, that I'll be touching on. Next slide. So in the core components, for efforts that are most successful, really thinking very broadly, consumers, advocates, family members, but also the providers, the clinicians, not to forget the administrators, the funders, the policymakers, and the evaluators. Really, it's essential to develop a shared vision and then to build opportunities for listening and collaboration. So in many ways, this early phase of MHAP is that's where we are. That ongoing piece, the evaluation, the questions that CDC recommends are the goals measurable? Are there resources to monitor? Is it updated regularly? And is feedback used meaningfully or continuous quality improvement? Next slide. So in the 5 steps, the problem identification, and being a public health entity, CDC recommends gathering information relevant to the problem and its causes, and then talking about how severe it is, how frequent it is, the scope and the financial impact. Are there gaps in the data? So sometimes we think we have it all, but really there's some significant data we'd benefit from. And then as we think about the problem, we're also thinking about what are potential solutions. Next slide. So the policy analysis section, which really, in my experience, is both challenging and exciting, and that's researching and identifying options. Have they demonstrated effectiveness, or the evidence-based practice model? But they can also be practice-based. Does it fit the local context? What are the resources needed to accomplish this? Is it feasible and sustainable? And then what would be the impact? Are we going to cover a lot of people but maybe not address the most severe issues, death and disability? Or the other way, will we just target the most complicated issues? Someone might need to be muted.
Look into the
I'll keep going. We want to ensure that gaps are addressed, and we're increasingly aware that diverse communities often have very substantial gaps. Keep in mind, is there a potential for harm? And the unintended consequences can really blindside us, but there is the potential to really look carefully at, are there examples where harm is done? And then, because resources are needed, what's the cost compared to the benefits? And then lastly, to prioritize the options. Next slide. Strategy and policy development. So how do we get from a problem and a potential solution to actualizing? How will it operate? What's needed? How do we engage the stakeholders if we haven't completely at the earlier phases? And then one of the things I found in working with legislators is not to tell them what to do, but if there are clear examples or even drafts, that can be helpful for them to say, might not work, or that sounds reasonable. That gives us a framework. Next slide. Then the enactment. Now, this is getting downstream, so our group will be in the earlier phases, but working with the folks that are administrators, funders, policymakers, we need to be thinking long term. How do we enact that law regulation and put incentives in place or the practice? Next slide. Then in terms of implementation, it gets down to the nitty-gritty, and I found it especially helpful to work with folks at the state level because they're often involved with not only advocating for the funding, but writing the regulations. So how does that policy move into practice or at a clinical level, organizational level? What are the indicators or the metrics we use to evaluate? Because we need to keep in mind that evaluation needs to be ongoing. How do we coordinate and build capacity so that this is able to be sustained? And then we need to be asking, okay, we had great ideas. How are we assessing that implementation, ensuring compliance? So that's hanging in there. And then once again, is that funding or other resources, the workforce, sustainable? So last slide. Just a reminder of that, we're kind of in a loop there. So this is one model. There are many frameworks. Thanks so much, and thank you, Sita.
Thanks so much, Dr. Imler. And now I would like to ask Diane to talk about Blue Ribbon Commission, the Governor's Blue Ribbon Commission on Mental Health. And Bryn, I wonder if you could pin Diane so everybody can see her.
Okay, should I start?
Yes, go ahead.
Okay. Well, the Blue Ribbon Commission was established by Governor Thompson in May of 1996. And if anybody else is around, it was still there in the mid-90s. You might remember there was a lot of hype at that time about managed care and how managed care was going to save us money. It was going to provide better services. It was going to do a lot of good things. But there was a lot of concern about managed care. And particularly, I think some of the county leaders were concerned about the impact that it might have on their county systems and the relationship with the state. And the state was embarking on the redesign of long-term care services, which was going to be a managed care system, and how mental health might fit in with that long-term care redesign. So those were some of the reasons that there was a desire to establish a commission to take a look at the mental health system. The membership of the commission was very broad-based. There were lots of different stakeholders. There were people from the counties, people from the legislature, people from the provider community, family members, what have you. However, there was only one consumer, and there was a backup for the consumer in case they got sick. Well, that was seen as being very stigmatizing. And there was a beginning consumer movement in the state, and a group of people got upset and went to the governor's office. And I don't remember if they had a sit-in or they carried signs or what exactly, but there was a protest about this. And as a result, it ended up that 7 consumers were appointed to the commission, and then I was appointed as an advocate for consumer rights and issues. So, and I think that had a tremendous impact on the outcome of what the recommendations were coming out of the commission. And I'm going to apologize. I use the term consumer because that's the language that was really for most of my career. I know that a lot of people would prefer not to use consumer, but so please accept my apologies, and I'll carry on with that terminology, but knowing that that's not the preferred terminology anymore. Okay, the recommendations, the report came out in about a year later. So the major recommendations were to the adoption of recovery as a guiding principle for the mental health system. And it's very interesting. The chapter on recovery was actually written by a consumer. It was the only chapter in the entire report that was the name of the author for the chapter was included. There was a focus on increasing prevention and early intervention services, decreasing stigma, a focus on consumer outcomes, development of better treatment and recovery services, including peer support, individualized assessments, individualized service plans, and a development of a managed care service delivery system. So those were the main recommendations. I'm only going to focus on 2. I'm going to focus on the managed care issue and demonstrations and what happened there, and then also talk a lot about the recovery implementation. So the state went forward with I guess it was like a request for participation, and 4 sites were chosen to be the managed care demonstration sites. They were Dane County, Milwaukee County, Kenosha County, and the 3 counties up north of Forest, Vilas, and Oneida. So there was a mix, obviously, of urban and rural systems. And Dane County, interestingly enough, wanted to include physical health as well as mental health in their project. There was a 2-year preparation time. Where there was a lot of focus on, there was not only interest in the funding, but also making these counties as sites for people to learn about recovery and recovery implementation. So there was a lot of training. They identified outcomes that were the desired outcomes from services, developed elaborate assessment processes. So there was just a tremendous amount of work done. However, it never moved to the capitated system. And the reason it never moved to the capitated system is because there wasn't enough money. So when they took the money that was available through Medicaid and the federal share of Medicaid, the money that was available through the state, which was partly the state match for Medicaid, plus the other state money through community aids and that's involved in mental health services, and the county dollars that were put into the system. And each county has a slightly different amount of dollars that they put in. When they put that all together in a bundle, and then try to figure out how they were going to capitate it and how they were going to provide an array of services to a specific population, they realized there just plain wasn't enough money. And so therefore, the counties didn't want to get stuck holding the bag, and the demonstration process ended. And I think it was part of the problem. They realized they didn't have enough money. The state was not willing to put in additional resource to provide the amount of money that might be needed. There also is the problem that maybe that Heidi might address as well, is we have tremendous variation from county to county in terms of the amount of dollars that are actually put in. So if you would actually go to some kind of a state system, how do you equalize that? How do you decide, is Dane County going to continue putting in the same amount of money that it does? Forest, Vilas, and Oneida, they're putting in less. How is that all going to work out? So that was also part of the problem that kind of led to the downfall of the whole thing. And interesting, I talked with somebody else who'd been in the department at that time, and she said that the other thing to consider was that the state was very much involved in the long-term care redesign. That was the really big thing. That's where the big money was really involved. And so a lot of resource at the state level was put into developing the long-term care redesign. And I think that the mental health redesign suffered because of that. There was not as much resource. So as you're thinking about policy choices, look at the landscape and see what else is going on and what might be sucking up all the oxygen away from the thing that you're trying to work on. So the other thing was big thing out of the report was the implementation of recovery, and recovery to be the guiding principle for the mental health system. And it started off with a work group that was once again very wide variety of stakeholders, consumer members, family members, providers, people from counties, people from the state, a nice wide array of people. And for the first time, a consumer was hired at the Bureau of Mental Health. So Kellyanne O'Brien was hired, and Kellyanne became co-chair of that work group. And the first thing the work group did was to develop essentially a statewide plan. We worked for a year to develop a statewide plan for the implementation of recovery, with short-term goals, long-term goals, medium-range goals, but essentially took the time to try to think through what needed to be done in order to implement this concept. And we developed a plan both for statewide, and we also developed a plan for the managed care entities. I'm going to focus more on the statewide stuff because that's what I was involved with. We were we had a work group, and then that work group morphed into the recovery implementation task force. And I checked recently, and that task force still exists. So 20 some years later, that task force was established in 1999 is still going. And I think one of the things that was very helpful at the beginning was we had a woman whose name was Nora Jacobson, who worked with us. She had a PhD in sociology, and she was doing a postdoctoral fellowship at the university. And she took on this project as something for her to kind of become involved with. And so one of the things that she did was she did a very extensive literature review about what recovery meant. And how did you operationalize it? How did you conceptualize it? And she came up with something we called a conceptual model of recovery. And that model focused on the internal conditions about what happens within the consumer and the external conditions about what is going on in the service system and in the broader community to facilitate recovery. So it wasn't just the consumers go off there and do their own thing, or that it's all up to the service system to somehow bring this about. It was seen as a interlocking kind of set of activities. And that was very useful to have this conceptual model that we then were able to use. The internal conditions were hope, healing, empowerment, and connection. And the external conditions were a positive culture of healing in the agencies and providers who are involved in this in providing mental health services, an array of community-based mental health services, and a focus on human rights. So that then provided us with a basis to develop a training program. And that training then was taken all over the state. We also developed a video, we developed a consumer packet of information, and we developed a self-assessment for agencies to be able to take a look at themselves about how they were doing in terms of implementing recovery concepts. So there was a lot of stuff was developed essentially. In addition to the work that the task force was doing, there was also a contract with a group called Recovery in Action. And Jen Koberstein, who's part of this group, was very much involved with that. And they were focused on the demonstration sites. and they produced a lot of material on practitioner competencies in terms of delivering recovery-oriented services, best practices, a very robust list of consumer outcomes, training on consumer choice, and there was a lot of concern about risk, about liability perhaps from providers who might let people make decisions that were not in their best interest. So there was training around that. So there was a lot of training and consultation that was done during that very, very early time. So what are some of the long-term impacts of all of this? Well, thinking about looking at Rick's, statutes and policy, well, we actually modified the state statutes. There was provisions in section 51.03 where the definition of recovery was provided, and more aspirational kind of language about what the state ought to be doing. And then I think, as I look back and I think about what happened, the managed care thing collapsed, but there was still a lot of interest in providing a more robust Medicaid-funded service. And out of this came the development of comprehensive community services. So CCS was not directly developed by the Recovery Task Force, but the same group of people who were involved in recovery implementation and thinking about it were people who were instrumental in approaching the state about developing this service. And the people in the Bureau put together a group to develop the principles for CCS, which was heavily influenced by once again, the people who are part of the task force and the other demonstration projects and what have you. So I think there was a direct link between the Blue Ribbon Commission recommendations and the development of CCS. And it's very interesting, if you look at the CCS regulations, you see language that parallels a lot of the material that was actually in the Blue Ribbon Commission. Then this next thing that happened really was the development of Peer Specialist. And the Peer Specialist Subcommittee was a subcommittee of the Recovery Task Force. And it was established in 2006. And once again, Wisconsin doesn't say we're going to do it like everybody else. Instead, we decided we wanted to do our own thing. So we got together a group, once again, a broad-based group, to identify the core competencies that peer specialists should have, developed a training, certified certain training programs that could meet these core competencies, developed a test. I remember sitting there with these guys from the university who were the ones who knew how to develop test questions and taking all these competencies and trying to figure out how to build tests around it. And then finally the certification. So then the certification came into being, it was 4 years after the initial rollout of the initiative. Concurrently, consumer groups were very active. There were consumer-run services in 26 counties. There was a leadership academy where consumers were being trained about how to be on boards and committees. And then in 2014, as you know, peer respite services were developed. Once again, not directly related to, say, the task force of the commission, but the long-term outcome, I think, of the stuff that was put in motion by the task force, the Blue Ribbon Commission report. So I think that when I look back at Rick's typology, so I think some of the reasons I think that this has had lasting impact is that there was a large stakeholder involvement. There was a lot of planning and strategy put into how to roll this out. There were resources that were devoted to it. There was actual policy development in terms of state law, regulations, programs support, and then, of course, the implementation is ongoing. Maybe the piece that's missing is the evaluation in terms of the looping back about how effective all of this is and has been. But it is interesting to think back about from a conceptual framework about what was done and what was accomplished and what is still ongoing. So I will stop there.
Thanks so much, Diane. It was just fascinating. It was just wonderful. Now I would like to ask Heidi to talk about the mental health substance use infrastructure study.
Thanks very much. Thanks very much, Sita. It's
Yeah.
really a pleasure to be here this afternoon and to see so many familiar faces. So thanks for inviting me. It was a little bit of a step back. 14 years ago was when this study began, and it spanned a little bit over a year. Because there was a phase 2 as well. But just to talk a little bit about the background and the scope, because it did have some differences from the Blue Ribbon Commission that Diane referred to. So if you could advance the slide, Sita. So the purpose was really one slide back.
Oops, sorry.
No, that's okay. The purpose was really to review the current funding and service delivery system, and to look statewide, to do a little bit of a deeper dive on some selected counties. And I see on the Zoom that Kathy Cawley, who was part of the steering committee, and her county, Jefferson County, was one of those 9 counties selected for a little bit of a deeper look. And it was to look at Wisconsin's experience, but then also to look at some other states, and to really do this for state policy consideration. It was the study was intended to help inform the development of the 2011-2013 state biennial budget at the time. And the focus was on infrastructure, so more on the broader systems and structural issues, as opposed to operations or kind of practice model, or some of the things that the Blue Ribbon Commission maybe got a little bit more involved in. It was to build on previous study efforts, so we certainly reviewed the Blue Ribbon Commission report, and there were also some other papers. The County Human Services county directors and board members at the time did a visions paper, if that rings a bell with anyone. And then there was the Wisconsin Council on Mental Health also did a briefing paper. So we looked at all of those previous efforts that had been done. And we really tried to review some state and national initiatives that could impact the mental health system as well. And that, as Diane already alluded to, managed long-term care, came to be known as family care, was expanding. At the federal level, we were looking at mental health parity legislation. There was federal health care reform legislation going on. So it was very much in keeping with what was going on throughout the state and nationally. And the study was guided by a 12-member steering committee, which had consumer representation. Actually, our project team also had consumer representation. And it was that 12-member study steering committee, in conjunction with the Department of Health Services, that really worked collaboratively to guide the study. So it was the steering committee that decided which states we were going to look at, which counties we were going to look at a little bit more closely. And some of the findings are, there are some primary sources of funding. Just one more back, Sita. Sorry about that. And certainly the biggest ones are Medicaid, community aids, and county revenues. And that really was county property tax levy revenues, to a lesser extent, federal block grant and private insurance and individual payments. But those were the funding sources that our study and the data analysis looked at. And we looked at the Human Services Reporting System for the county data. We looked at Medicaid encounter information for the Medicaid data and try to kind of piece that all together. And one of the things we looked at is what's happening nationally. And there was a national study that looked at all different county mental health substance use systems. And Wisconsin really at the time was in the minority of states in terms of county administered systems. And in Wisconsin at that time, in 2009, county system funded more than 70% of these service expenditures and served more than 40% of mental health and substance use consumers combined, but certainly more in terms of just substance use consumers were served within the county system. And as Diane already mentioned, there was lots of variation between counties, 72 counties, 3 multi-county systems, 67 single county systems. And you can imagine with property tax revenues being such a large funder of mental health substance abuse services, that there was a lot of variations. County boards, you know, had different priorities for funding, and so that you could really see the variation in terms of both the number of consumers per thousand population served and the per capita expenditures in different parts of the state. So on the next slide, one of the, you know, the really kind of key finding was, and again, it's interesting, you know, listening to Diane again and reviewing the executive summary of the Blue Ribbon Commission report, you know, managed care and Medicaid managed care was clearly one of the systems that we looked at. And what really became apparent is that Wisconsin had two very distinct publicly funded systems for mental health substance abuse services. One was county administered. That was, you know, the definitions were set in statutes, but they were very broadly defined, very much subject to variation among counties. And then you had the Medicaid managed care system with the contracts that the state entered into with Medicaid managed care entities that were very clearly defined, very specific service eligibility and benefit requirements. And you can imagine that the two systems were not very well aligned, and that it resulted in complexity and inconsistency and conflict between the two. So we also, as part of the study, we looked at what were some of the national trends. So on the next slide, slide 5, we looked at, certainly there was a trend nationally and a preference for integrated care models, whether that be between mental health and substance abuse services, mental health and physical health services, or mental health and other human services and disability services, including long-term care. But clearly, we were seeing nationally that was the trend. And then certainly the role of Medicaid as a major funder of these services. And then also an interest and a move toward more financial incentives to purchase for value and outcomes. So we looked at that, and certainly we looked at that when we addressed some of the 5 selected states. We looked at Minnesota and Ohio, which both have county-based systems, had county-based systems more similar to Wisconsin. We looked at New Mexico and North Carolina, which had both gone through pretty substantial reform efforts that had been studied. And we also looked at Oregon, which was moving to a greater integration of services, mental health, and physical health care. And so that's fine. You can stay on slide 6. And so we interviewed those states, and we talked to members from the state agencies, but also members of organizations like Diane was involved with the federally designated advocacy and protection agencies to get more of the consumer perspective of how those reform efforts went. And some of the lessons learned from those states was that pacing and sequencing is really important. Don't try to do too much too quickly. These are major system changes, and the one thing that you want to prevent is doing harm to individuals who are relying on these services. So a lot of suggestions about piloting reform. Also looking at implementing a uniform benefit or core benefit set first before you engage in other aspects of reform, and really addressing service capacity and workforce issues. If you're going to have a core benefit package, you need to make sure that there's a provider network there that's going to be able to competently provide those services, and that people are going to have adequate access to care. And then again, to address the full cost of reform and the need for additional state funding to make reform work. And again, this goes back to Diane's point that simply not enough to take the existing resources and try to divvy those up, that there was underfunding in the system, and there was a need for more state support. So On the next slide, you'll see we dealt more with, we looked at more kind of the structural issues. And again, this was in the backdrop of family care, managed long-term care expanding throughout the state. At the time, I think family care it wasn't statewide. And I think it was only maybe in 48 or so counties at the time. And SSI managed care wasn't statewide either. So we looked at some scenarios, and the way to think about this is these were, first of all, the models were models for funding the system differently. And then we had within each of the models, we had different pathways for achieving that particular model. So lots of options. We did not recommend anything, nor did the steering committee. These were simply laid out. And it was, on the one hand, kind of least disruptive was continuation with the county-based system, but more influx of state resources. Model B was a county collaborative system, very much like what statutes currently allow, where counties can voluntarily come together as groups and provide certain services. A multi-county system, that would have been a move to a more mandatory regional system. And then the public-private integrated care system, that would be counties potentially working with private entities to provide behavioral and primary and acute care. So, but underlying all of these scenarios and all of these different models and pathways were these principles. I won't go through them, but you can see, strong consumer choice, county roller choice. And again, these were all developed in conjunction with the steering committee. And then overall, the 4 reform goals that were identified were equitable access to services, accountability for consumer outcomes, equitable and affordable funding, and service efficiency. So again, those were kind of the guiding reform goals. And for all of the additional funding that was being looked at for the system, those additional resources would have to have some kind of assurance that the system and those local agencies would be able to address these reform goals. So just quickly fast forward, what was accomplished? There was, after the study came out in December of 2009, there was a large summit that was held in the central part of the state. I think it was in Stevens Point. Over 200 stakeholders attended that. And there were, much like what you're having today, small breakout sessions. But the consensus came out that really there were 2 areas that were the focus. And one was the development of a core benefit package and a regional approach. And so there were then 2 work groups that were developed with pretty extensive stakeholder input around those 2 focal areas. And there was a request for proposals for a regional approach. And it was really felt that we needed to do a more, kind of voluntary, least disruptive approach to system change. There has been certainly in some areas greater state financial participation in the system. For example, CCS, as Diane mentioned, was, at that time, CCS wasn't statewide. And a lot of counties were reluctant to get into it because counties were providing the non-federal share of comprehensive community services. And the state did provide the non-federal share then. So that was, so there certainly were some gains, but I think what we're going to talk about in the breakout sessions is that more is possible. And I had some questions or some points on the last slide, but maybe it would be best to leave that. I don't want to dig in too much to the discussion time when we're in the breakout groups, but it probably is worth looking at some of those findings again from that study and seeing what does the updated data tell us about the current funding mix, the consumers served, and where there's variation and gaps. And what have been some of the changes, the impact of some of the changes since 2009. And then really to review a little bit the requirements and the oversight of Medicaid managed care and county administrator services. But again, there are contracts that are pretty detailed, but are those contracts being enforced on a regular basis, and where are the gaps? And then I think the kind of the big question, the $64,000 question is, how can you kind of leverage the opportunities yet address the challenges and any risks to create a better experience for individuals receiving services and for a more effective system overall. So sorry to race through that, but I just wanted to get all that information in before we broke for the smaller sessions.
Thanks so much, Heidi. It was packed with information and a lot to think about. So now, folks, we're going to go into breakout sessions. I think we'll stay in breakout sessions until 3:40, which means that we'll have a little less time to report out at the end. But it does seem like it would be really good for everybody to have a chance to chew on this together. And we have 4 questions that we're going to put in the chat right now, but you should have received them in your handout. What do you see as the major impact of these reports? What happened to encourage or impede implementation that we should take note of? What recommendations remain unrealized that are important for us today? And what's different in the environment today that we need to take into account? And so each group, as I said, is going to have a facilitator and a scribe. And I'll ask Bryn if she would open the breakout groups, and we will gather back together at 3:40. Thank you. Bryn.
Kathy, I know has her, I don't know if it's on this question, she has her hand up as well, but there were specific aspects of that when we were talking to the counties more specifically. They were sort of questioning, are those contracts really being enforced the way they're written with the specificity that they're written in?
And just real quick, if there's time, along that same line, one other part of those contracts that sometimes people aren't even aware of is there is a benefit for inpatient psychiatric hospitalization that some people aren't aware of, and sometimes it isn't used, and then there's sometimes the struggle to have it used.
Welcome back, everybody. I hope you had a really engaged conversation, and I'm wondering if Kathy Marklin is back in the room yet, and if so, if you would.
I am here, Sita.
Great.
And as much as this was a really challenging task, it's such a great sharing happening in our room. I'm sure, I'm hoping all of you had also rich exchanges and conversations. And so really our task here is to share on 2 things, sort of what did we learn in those conversations, kind of key learnings, and how does it now apply in the work that we're envisioning to do together? So those are the 2 things that we'll be asking, and from each of the groups, if the scribes or the facilitators, I'm not sure who's going to pick up the baton here, to share forward just a few things from your room, like those salient points about what we learned from each other and from extracting from the presentations that you want to make sure we share forward with the group. And so I don't know if I should walk through how many breakout rooms we had here, Sita. If people know their rooms.
I think just ask a facilitator to sing out.
All right. Who wants to start?
I can start from our group.
Thanks, Jen.
Yeah, I think a big part of our discussion, and I'm just going to hit on one thing because I think we don't have a lot of time, and I just want to hit on one thing, is that we talked about how there was a desire to move toward regionalization, but we don't know how to get there. And the 72 county system being very complex for family members and clients and staff, and how do we move forward with a more regionalized system that's more consistent across the state. So I think that was, for me, the big takeaway from our session.
I'll jump in. There was several great points. A key one was moving to more recovery, person-centered, and stigma reduction that came out really over the past 20 years.
I'll jump in. I won't mention some, but we had a great discussion. I think all of you that were in our breakout group, but just a couple of things that haven't been mentioned yet. One is that a Medicaid expansion money has been left on the table, and we're continuing to pay a price for that. That goes hand in hand with another thing that was mentioned, just sort of the political backlash and issues that we're facing. One other one that I want to mention is the need for a robust data system for children and adults, and then giving thought to the social determinants of health. I think that's something we do more now, and Hugh reminded us so that's a change, but something we still have to work on. And the last one is just my own thing that I sort of mentioned, but just the need for evidence-based practices available for everyone.
In our group, we talked about the presentations, the presentations that were shared, that there was time and investment into working on those projects. And right now in our current day and age, our resources are slim, turnover is high, things are happening at a fast clip. A lot of people need a lot of resources, and we are doing the best we can to navigate all of those systems and bring people together. And although we want to bring people together more, it's very complicated and hard.
Yeah, one other point I should make, and that reminded me, but just the workforce issues. We have, we don't have enough providers. We have providers struggling to get licensed, and then all the technical issues that go with that, and electronic health records and post kind of COVID issues.
To throw in an additional one that a couple people resonated with, and that is the bifurcated nature of funding and services, the county community-based model, the medical model, and managed care. That really can be challenging for the consumer and access to care.
Yeah, our group echoed that too, with the shift to more recovery-oriented services and the expansion from recovery from just the viewpoint that it was a substance abuse recovery to more mental health recovery or dual diagnosis. Another thing that our group came up with, among other things, was the disequity among different counties and sort of territoriality in terms of what resources are available, both in terms of money and in terms of staffing and in terms of agencies even. Mental health courts also came up within our group, and that, you know, we still have a relative paucity of mental health courts, but the more kind of enlightened vision right now is not just mental health courts, but dual diagnosis courts that take into account mental health, substance abuse, considering the overlap, as well as trauma.
One other one I want to be sure to bring forward, and that's veterans. Being sure they're involved in the dialogue and being sure that there's continuity between systems for veterans.
So I'll jump in with something that we discussed in our group too about sort of what's different in the environment today. And that's where we're at in terms of technology and what's part and how technology feeds into service delivery, whether it be teletherapy services and other technologies that are responsive or that are used within the context of service delivery, and how that becomes a resource to support greater access. I think the other thing was the focus on what we know about brain development and the transition age changes. And so thinking about that, the unique time of that transition age and the crossover that happens in systems at that time.
And we also discussed how the recent years have really wiped away a lot of the stigma that used to exist. And so mental health is much more accepted now, and the need for mental health care is much more accepted now, along with a lot of trauma being recognized, especially in children and youth. So, you know, there's more openness to getting care and a rising demand for care, and that's hitting right at the time when we have a dire workforce shortage, partly because of demographics and partly because the pandemic wore everybody out.
Other groups have pieces that haven't been mentioned here yet. Things that you learned, how does that apply now in our work? Brad, I saw you unmuted.
I just muted for a moment, so that's why I came off.
Gotcha. Okay.
We didn't talk as much about this, and maybe I should have brought it up during our small group discussion, but there's a lot of money that goes into mental health that's not related to direct costs, that, you know, if we could capture that and figure out how to save it, and that all includes homeless, incarceration, social services, child protective services, all those sorts of things are related to mental health. And if we adequately bring those into the equation, it might increase the likelihood that we'll see better equity in funding for mental health.
And another thing that was mentioned in our group was that the continuum of care for mental health, we focus in on the continuum of care for mental health. We also sometimes focus in on the continuum of care for substance use, and sometimes we focus in on the continuum of care for children, but those continua of care have elements that are alike, and maybe that's, you know, that's part of what we should look at in terms of making the system more consistent, is look at the general medical, primary care, disability, physical disability, continua of care, and see if there's a cross-cutting way we can make this simpler somehow. And then the other point was that a member of our group was in Colorado when they regionalized, and it was very complex, but it happened and it's still going. So buckle your seatbelt, is, you know, if you want to do this, but it's worth the trip.
One of the things I found interesting in the group I was in was the issue of people who are dually eligible for both family care and for mental health services, and the problem of collaboration. And
Anything else? I think I'm about to hand it back over to Sita here, but anything else that falls into that, how it applies to how we work together now? I will say, I'll share from my perspective that I think that the piece that that Diane shared, at least to kind of start us out around the strong element of the voice of lived experience, and making sure, and it's been shared a little bit here, but just making sure that that stays centered in the work that we're doing, seems like a clear strength that emerged from the learning. And then I just also wanted to note sort of what's, I think more focus currently around diversity and questions of having culturally competent practice, and making sure we have diversity in the provider community and representation that occurs within the peer recovery space as well, but that being true all the way up through and across our continuum and our provider community.
And if I could throw in something that Heidi said around accountability for funds that are being approved now, and in terms of the services and the collaboration.
I'll add one more, and then I don't think it's quite gotten hit on, but it came up in our group. I think Sita said it, just in terms of how the challenges of navigating all of this is for individuals and families. And then related to that, of just the complexity that all the providers, whether it's counties, all of us that are trying to provide these services face, and how much of a barrier that is to meeting these demands that we're just seeing are just increasing exponentially.
If I could have a moment, this is Rebecca. One piece that we haven't talked about is the number of individuals who have been moved into jails and prisons who are mentally ill.
Yeah, it's like the criminal justice system has been the default when the mental health system fails, and that's completely unacceptable. You know, it's just number one should be illegal, and number two is immoral. Yeah.
Well, and I would say on the children's side, we see the similar thing with Children's Protective Services, right?
Absolutely. Well, everyone, thank you very much, and thank you, Kathy, and please join me in thanking Diane and thanking Heidi and thanking Rick for really a very rich section today. And thanks to all of you for engaging. Like I said, we are recording this and we will send it out to all of you along with a brief summary of this report. We'll also send out a little poll on what time of day or week. We've got a few possibilities of what times might be possible for learning sessions going forward. We're hoping to hold these on a regular basis, and we'll just sort of delve into what we need to explore together as we move toward ongoing system change and ongoing system reform. And speaking of system reform, there is a Mental Health Action Partnership meeting on January 31st. It will be an online meeting, and we would love to have all of you come. And also bring along someone else with you, preferably somebody who's kind of newer in their career and or working on the front lines and really can, say what's like, and people from diverse communities who maybe, really have a completely different take on this whole system. And so please bring those people into the conversation. And that's on January 31st. We're going to talk about MHAP structure and process, and we'll also tie in our coalition work, some local and regional coalition work that's been going on for 8 years with an Advancing a Healthier Wisconsin grant. It's called the Advancing Behavioral Health Initiative, and we've got Dr. Michelle Broadus-Sun with us here, so she'll talk a bit about that. And then we'll look at policy priorities and work groups and how we can divide ourselves into action groups that can actually develop action plans for consideration by the whole MHAP and how we can begin to move forward on policy change. We're going to look at low-hanging fruit, like the things that can be done by just like replicating without a whole lot of extra policy or money, and just like looking at best practices that we can share with each other. And then we'll kind of work our way out to things that require A, more money, B, more policy, C, more structural change. And as we've been talking about, the structure in Wisconsin is very complex. So we need to, that's a really long term, who knows how many years it's going to take us to get there. But the idea is that it's not one and done, it's ongoing. And we are citizens or a community stakeholder group that will keep moving this ball forward. So please join us for the January meeting. And I think that's all I had to say. And the partnership is, what we're really looking for, a cross the lifespan, cross the continuum partnership. So think about who needs to be in this room with us.